Now we are going to start acute abdomen. So what is acute abdomen here? Patients are having signs and symptoms of abdominal pain plus tenderness. So how we are going to make the diagnosis? The mainstay of diagnosis obviously remains a good history, physical examination, and it is complemented by laboratory and radiological studies. So in acute abdomen, the mainstay for diagnosis remains a good history and physical examination, and it is complemented by laboratory and radiological studies. So whenever we are taking history, we should emphasize age, gender, and history of previous abdominal surgery. Why? Because related to age, gender, and previous abdominal surgery, what it is associated with different problems which are causing acute abdomen. Suppose we are talking about age, so you know that appendicitis, mesenteric adenitis, this is more common in young patient. And if you are talking about biliary tract disease, diverticulitis, intestinal ischemia, this is more common in older population. So what is the significance of age? So appendicitis and mesenteric adenitis, it is more common in younger patients. So this is more common in younger patients. And biliary tract disease, diverticulitis, intestinal ischemia, this one is more common in older population. This one is more common in older population. There are certain non-surgical causes of acute abdomen, means non-surgical causes in which patient is having acute abdominal pain, patient is having abdominal tenderness. So what are those non-surgical causes of acute abdomen? See one by one. First, see the endocrine and metabolic causes. In endocrine and metabolic causes, first is acute intermittent porphyria. Here also, patient is having severe abdominal pain. Apart from that, Addisonian crisis, diabetic crisis, some of the patients who are having hereditary Mediterranean fever, and uremia. In all these cases, there is abdominal pain. What happens? Uremia? Uremia can cause colonic pseudo-obstruction. So there can be abdominal distension. Uremia can also lead to abdominal pain. After that, hematological causes. Patients who are having acute leukemia, or sometimes patients of sickle cell anemia, they have sickle cell crisis. In both of these cases, there is severe abdominal pain. There are certain toxins and drugs which can also cause acute abdomen, like black widow spider poisoning, lead poisoning, apart from lead, any other heavy metal poisoning, and narcotic withdrawal. So all these are non-surgical causes of acute abdomen where patient is having abdominal pain and abdominal tenderness. Now see the important points related to anatomy and physiology. First, abdominal pain, it can be visceral pain, parietal pain, referred pain. One by one we are going to discuss. First, see important features related to visceral pain. Visceral pain. So you know that visceral pain, it is vague and localized. So imagine the visceral pain, it's vague and localized, and if it is localized to epigastrium, so generally the origin is from the foregut. If the pain is around periumbilical region, so origin is from the midgut. And whenever it is in the lower abdomen, where exactly in hypogastrium, then origin is from the hindgut. So what happens? Visceral pain, it is vague, and imagine it is localized to what? Epigastrium, or it is localized to periumbilical region, epigastrium, or periumbilical region, or it is localized to lower abdomen, that is hypogastrium. Hypogastrium. So whenever patient is going to perceive the pain where in the epigastrium and it is the visceral pain, origin is from the foregut. Origin is from the foregut. If it is in the periumbilical region, the origin is from the midgut. And whenever it is in hypogastrium or lower abdomen, origin it's from the hindgut. This is from the hindgut. So one important question, you tell me, what is the cause of visceral pain? Visceral pain is usually due to distension of hollow viscus. What is the cause? It is caused by distension of hollow viscus. Distension of hollow viscus. Clear? So you know that if a patient is having small bowel obstruction, what happens? There is distension of hollow viscus. So initially patient is having colicky abdominal pain. Later patient is having multiple episodes of bilious vomiting. And if it is complete obstruction, so what happens? There is non-passage of feces and fetus, that is obstipation. So this is visceral pain. Second is parietal pain. Parietal pain. And you know that this parietal pain, it is sharper and better localized. Parietal pain is sharper and better localized than visceral pain, and it corresponds to nerve roots that supplies the peritoneum. So if we are going to compare this parietal pain from visceral pain, it is sharper and better localized. So this is sharper and better localized than visceral pain, and it corresponds to nerve roots that supply peritoneum. So it corresponds to nerve roots that supply peritoneum. Clear? The third pain is referred pain, and you know that what is referred pain? Here the pain is perceived at the site that is distant from source of pain. So here pain is perceived, this pain, it is perceived at the site distant from source of pain, at the site distant from source of pain. Clear? So these are the three types of pain: visceral pain, parietal pain and referred pain. Now imagine there is referred pain to left shoulder. So you tell me what is the cause of this referred pain? So referred pain to left shoulder, it is because of involvement of which nerve root C3, C4, 5. So it is C3, C4, C5. So if the patient is having some problem related to heart, left hemidiaphragm, spleen or even tail of pancreas, in that case there is referred pain to left shoulder. Similarly, in which cases there is referred pain to right shoulder. So whenever some pathology is there with gallbladder, liver or some irritation of right dome of diaphragm is there, right hemidiaphragm, in that case there is referred pain to right shoulder. So we discussed that whenever there is pathologies of heart, irritation of left hemidiaphragm, spleen or tail of pancreas, there is referred pain to left shoulder. Similarly, in gallbladder pathologies, when gallbladder is inflamed, liver pathologies, or there is irritation of right hemidiaphragm, there is referred pain to right shoulder. Sometimes, whenever the stone is there in the ureter, there is radiation of pain to scrotum and testicle. So sometimes there is radiation of pain to scrotum and testicle whenever there is stone in the ureter. Stone in the ureter. So you can see here the location and causes of referred pain in commonly encountered situations. Perforation is one of the common cause of acute abdomen. So what happens in perforation? Bacteria or visceral content goes into peritoneal cavity. So in perforation, what happens? In perforation, bacteria or visceral content, it goes into peritoneal cavity. It goes into peritoneal cavity. Okay. And whenever bacteria or visceral content, especially the fecal matter, when it goes to the peritoneal cavity, peritoneum responds to such insult. How? By increasing blood flow, by increasing permeability, and sometimes forming a fibrinous exudate at its surface. So here, peritoneal cavity responds to such insult by increasing blood flow, increasing permeability and forming a fibrinous exudate on its surface. After that, what will happen? There is generalized or localized loss of intestinal motility. There is generalized or localized loss of intestinal motility. Generalized or localized loss of intestinal motility. Clear? After that, what will happen? There is formation of adhesions. So it leads to formation of adhesions. So these adhesions can be formed between loops of bowel. The adhesion can be formed between bowel and omentum and sometimes between bowel and abdominal wall. So adhesion can be formed between loops of bowel and omentum and sometimes between bowel and abdominal wall. So it helps to localize the inflammatory insult. So what happens? It helps to localize the inflammatory insult. Clear? So whenever it is going to localize the inflammatory insult, sometimes there is formation of abscess. And whenever there is formation of abscess, what are the symptoms? Patient will be having sharp localized pain. There will be sharp localized pain but with normal peristalsis. And if there is diffuse process, imagine patient is having duodenal perforation. After that, what happens? Patient develops peritonitis. So if there is diffuse process, it results in generalized abdominal pain with absent bowel sound. So this is localized process. If there is diffuse process like in duodenal perforation. So if there is diffuse process, in this case, what happens? The patient will be having generalized abdominal pain. Patient will be having generalized abdominal pain. Apart from that, absent bowel sounds. Absent bowel sounds. Now, when patient develops peritonitis, it is because of peritoneal inflammation. Peritonitis, it is because of peritoneal inflammation. Clear? This peritoneal inflammation, it can be inflammatory insult caused by gram-negative infection with enteric organism like E. coli or anaerobe. So it can be caused by infectious organisms. Inflammatory insult by infectious organisms. Clear? And after perforation, usually it is gram-negative organism, E. coli. So either it's gram-negative enteric organism, or in some of the cases it is anaerobe, and you tell me which anaerobe is present in fecal matter, Bacteroides fragilis. So if gram negative enteric bacilli, E. coli, or sometimes anaerobe, right? There are non-infectious causes also which can cause peritonitis. The classical example is pancreatitis. So peritoneal inflammation, it can be caused by infectious organisms, and there are non-infectious causes. There are non-infectious causes also, like acute pancreatitis. Acute pancreatitis. So any patient who is having peritonitis, what happens? Patient is having severe tenderness all over abdomen. So in patients of peritonitis, what happens? Patient is having severe tenderness. There is severe tenderness. Rebound tenderness may or may not be present. Means plus minus, it is plus minus with or without rebound tenderness, and the patient is having guarding. So there is guarding in patients of peritonitis. There are certain other types of peritonitis. One of the classical example is spontaneous bacterial peritonitis. For spontaneous bacterial peritonitis, ascites is mandatory. Clear? So what is the most common cause in children? Nephrotic syndrome. And what is the most common cause of ascites in adults? It is cirrhosis. So one of the type of peritonitis, that is spontaneous bacterial peritonitis. And if you see this spontaneous bacterial peritonitis in children, what is the most common organism responsible? This is group A streptococci. So in children, it is group A streptococci, and in adults, it is E. coli. For spontaneous bacterial peritonitis in adults, it is E. coli. There is a second situation in some of the patients who are having CRF, chronic renal failure, and if they cannot afford renal transplantation, and they cannot afford hemodialysis also, if the patient is on chronic ambulatory peritoneal dialysis, so what we do, we insert a peritoneal catheter for peritoneal dialysis. So there is one organism which is going to produce slime, and that organism colonizes the catheter. What is that organism? Staph epidermidis. So peritonitis can also occur in patients of CAPD. So if there is peritonitis in patients of CAPD, full form is chronic ambulatory peritoneal dialysis. And what is the most common organism? Here, the most common organism responsible, this is Staph epidermidis. It's a question. This is Staph epidermidis. Clear? Staph epidermidis. So all these are questions. Spontaneous bacterial peritonitis, most common organism in children, group A streptococci, in adults E. coli, and most common organism responsible for peritonitis in CAPD, that is Staph epidermidis. Detailed and focused history, it's important and it's essential for accurate differential diagnosis. In acute abdomen, obviously patient is having pain and tenderness. So how to proceed? So for pain, what we have to inquire? We have to inquire about nature, onset, duration and progression. So related to pain, we have to inquire what? Nature, nature of pain, colicky, non-colicky, onset, insidious onset, sudden onset, for how long the pain is present, and progression. It is improving or it is worsening. Clear? Apart from this, what you have to inquire, the associated symptoms with pain. Associated symptoms with pain like nausea and vomiting. Nausea and vomiting. Clear? So these symptoms, nausea, vomiting, it begin before or after pain. After that, we have to tell the patient to localize the pain. Whenever patient is going to identify the pain with one finger, so pain is identified with one finger, it means this is more localized and it is typical of parietal innervation or peritoneal inflammation, which is identified or localized with one finger. Second, there is area of discomfort which is identified with palm of hand. So if patient is going to identify the site of pain with palm of hand, this is typical of visceral discomfort of bowel, or here there is solid organ damage. Clear? So with one finger, if pain is localized, usually it is parietal, and if it is localized with palm of hand, usually it is visceral or it's because of solid organ damage. Next important point, intensity and severity of pain. Intensity and severity of pain, it is related to underlying tissue damage. Now imagine patient is complaining of sudden onset of excruciating pain. Patient tells you that, sir, there was sudden onset of excruciating pain. So if there is sudden onset of excruciating pain, this kind of feature, it is suggestive of intestinal perforation, or there is ischemia because of arterial embolization. So it suggests intestinal perforation, or ischemia because of arterial embolization. Ischemia because of arterial embolization. Clear? Another important point, pain that develops and it worsens over several hours, it is typical of progressive inflammation or infarction. Now imagine patient is complaining of pain, clear, but this pain worsens over several hours. So there is worsening of pain. Worsening of pain over several hours, it means it is typical of progressive inflammation or infection, like it is seen in cholecystitis, it is seen in patients who are having colitis, or it is seen in bowel obstruction. So pain with progressive worsening, it is seen in cholecystitis, acute cholecystitis, it is seen in colitis, or if patient is having bowel obstruction, means worsening of pain, it's typical of progressive inflammation or infection. Some patients present with progressive pain means there is worsening, and some patient presents with intermittent pain. Clear? See the examples. Imagine there is infectious process. So what happens, obviously, if the infectious process is there is progressive pain. If it's infectious process, there is progressive pain because there is worsening of pain. And if patient is having spasmodic colicky pain associated with bowel obstruction, so if patient is having bowel obstruction, patient will be having spasmodic colicky pain. Second example, sometimes patient is having cystic duct obstruction in patients of acute cholecystitis. So in that case, what will happen? There is progressive pain. If there is cystic duct obstruction and patient is having acute cholecystitis, there is progressive pain. Second, patients who are having biliary colic. So here you can see that patient is having intermittent pain, right? So on the basis of these kind of features, whether it is progressive, intermittent pain, you have rough idea that what kind of condition patient is suffering from. Another important point apart from this, location, character and radiation of pain. It is important to elicit location, character and radiation of pain. Now whenever there is tissue injury or whenever there is tissue inflammation, obviously if tissue injury or inflammation occurs, it leads to visceral or somatic pain. Imagine there is solid organ visceral pain in abdomen, solid organ. Example, liver. Liver is located mainly in the right upper quadrant. Important point, solid organ visceral pain in abdomen. So it will be generalized in the quadrant of involved organ. Like whenever patient is having some etiology or pathology related to liver, so liver pain, it will be perceived in right upper quadrant. If patient is having small bowel pain, since it's a visceral pain we discussed, it is poorly localized, and small bowel develops from midgut. You know that midgut pathology, in cases of midgut pathology, patient is going to perceive the pain in periumbilical region. So if patient is having small bowel obstruction, there is poorly localized pain in which particular region? Poorly localized pain in periumbilical region. Why? Because it develops from midgut. Similarly, if the patient is having large bowel obstruction, especially colonic origin, so whenever there is large bowel obstruction, you know, most common site of obstruction in large bowel, it is rectum followed by sigmoid. So whenever there is large bowel obstruction, pain is located in hypogastrium, means it is centered between umbilicus and pubic symphysis. So pain in hypogastric region or in hypogastrium, so centered between umbilicus and pubic symphysis. Why? Because mainly it develops from hindgut. Genitourinary pain is also having radiating pattern. So initially, whenever patient is having stone in the kidney, so initially the pain is in the flank region. Clear? Why pain is there in the flank region? It is originating from splanchnic nerves T11 to L1. But pain radiates to scrotum or labia via hypogastric plexus S2 to S4. So in genitourinary pain also there is radiating pattern. Initially symptoms are in the flank. Initially symptoms are in the flank, and it originating from splanchnic nerves, root value T11 to L1. You have to remember. But this pain radiates to scrotum or labia. In males scrotum, females labia. Clear? Via hypogastric plexus, root value S2 to S4. Via hypogastric plexus, and the root value is S2 to S4. Then we have to focus on the factors which are going to worsen the pain and the factors which are going to lessen the pain. Like you know that some of the situations are there in which eating is going to worsen the pain, like bowel obstruction, biliary colic, pancreatitis, and food lessens the pain if the patient is having peptic ulcer. In cases of bowel obstruction, biliary colic, pancreatitis, diverticulitis, and bowel perforation, eating worsens the pain. So eating worsens the pain. Then food lessens the pain if the patient is having peptic ulcer or gastritis. So if patient is having peptic ulcer or gastritis, food lessens the pain. In peptic ulcer or gastritis, food lessens the pain. Clear? So we have to look for the factors which are going to worsen the pain or the factors which are going to lessen the pain. Food lessens the pain. I'm sure you have seen patients of peritonitis, because perforation peritonitis is very common in surgical emergency. And you have seen the patients of peritonitis. What happens? Patients of peritonitis avoid any activity that stretches or moves the abdomen. Why? Because of any activity, there is worsening of pain. So any kind of body movement worsens the pain. And if you see the posture of patient is lying supine and the knees are flexed. So patient is lying supine, knees are flexed. Why? Because there is lesser pain. So in patients of peritonitis, any kind of sudden body movement, it worsens the pain, and knees are flexed. So there is less pain if the knees are flexed. In history, associated symptoms and their timings are important diagnostic clues. Imagine patient is having vomiting. This vomiting can occur because of severe abdominal pain of any cause, and this vomiting can be result of mechanical bowel obstruction. So, associated symptoms and their timing are important diagnostic clues. Now, what happens if patient is having acute abdomen? So, pain of acute abdomen with underlying surgical cause. Imagine patient is having bowel obstruction. So, first patient will be having colicky pain. Later, they will be vomiting. So, if there is underlying surgical cause of acute abdomen, pain precedes the vomiting. Second, sometimes patient gives the history of constipation or obstipation. So, constipation or obstipation, it can result from mechanical obstruction. If there is complete obstruction, patient will be having obstipation, or sometimes because of decreased peristalsis also, patient is having constipation. Suppose patient is giving history of complete obstruction with absence of feces and flatus. Absence of feces and flatus. Clear? So this kind of presentation can be seen in bowel ischemia, or sometimes patients who are having bowel obstruction, there is significant distension, and because of this distension there can be perforation. So it can occur, or it is associated with bowel ischemia or perforation caused by significant distension. Perforation caused by significant distension. Some of the patients are giving history of diarrhea. So obviously diarrhea, it is indirect evidence of infectious enteritis. Patient might be having inflammatory bowel disease, or there is some kind of parasitic infection. So diarrhea because of infectious enteritis, inflammatory bowel disease, or parasitic infections. Important point, if patient gives the history of what? Bloody diarrhea. If there is bloody diarrhea, yes, here it is usually seen in colonic ischemia. So colonic ischemia patients have the history of what? Bloody diarrhea. So apart from history of present illness, we have to take careful past history also. Imagine patient is having pain in the flank, and patient gives you this kind of history that, sir, I was having this kind of pain 3 months back, 6 months back, or 1 year. So similar pain was experienced. Clear? So similar pain was experienced in the flank region. It might be an indirect evidence of what? Renal stone. Previously patient was having renal stone, patient was having pain in the flank, and after 6 months again patient is having similar pain. Second, past history. If patient is having history of appendectomy, patient is having history of PID, pelvic inflammatory disease, or cholecystectomy, so any kind of significant past history, it is going to limit the differential diagnosis. If in the patient already appendectomy has been done, it means the diagnosis of acute appendicitis is ruled out. If cholecystectomy has been done, acute cholecystitis diagnosis is ruled out. Medications can create or mask the symptoms of acute abdominal conditions. Imagine patient is taking high dose narcotics. So this high dose narcotics, what happens? It is going to inhibit the bowel movement. Clear? So it interferes with bowel motility and it leads to obstipation or an obstruction. Second, because of our narcotics, especially the morphine, it is going to cause sphincter of Fodai spasm. So whenever there is spasm of sphincter of Fodai, it might exacerbate biliary or pancreatic pain. And high dose narcotics can suppress pain sensation and alter mental status. So high dose narcotics interferes with bowel motility and it can cause obstipation, and sometimes the signs and symptoms of obstipations obstipation and signs and symptoms of obstruction, since it is going to cause spasm of sphincter of Fodai. So because of spasm of sphincter of Fodai, it exacerbate biliary or pancreatic pain. Exacerbate biliary or pancreatic pain. Another important point, it suppress pain sensation and obviously it alter mental status. Now see the role of NSAIDs. You know that what NSAIDs are going to do, it causes upper GI inflammation and there is increased risk of ulcer in duodenum leading to perforation. So NSAIDs can cause upper GI inflammation and perforation. It can cause upper GI inflammation and perforation. So what's the effect of steroids? Steroids can block protective gastric mucus production by chief cells, and you know that steroids reduce inflammatory reaction to infection. So what's the effect of immunosuppressive agents? Obviously it is going to suppress the immunity. So what will happen? There is increased risk of acquiring infections. There is increased risk of acquiring infections. What else it does? It is going to blunt the inflammatory response. It diminishes pain and limit overall physiological response. So these are the effects of medications, and you saw that medications can create or mask the symptoms of acute abdominal conditions. If patient is taking anticoagulant drugs, you know that anticoagulant drugs can cause GI bleeding. It can cause GI bleeding. It can cause retroperitoneal hemorrhage, and it increases the risk of rectus sheath hematoma. Increases the risk of rectus sheath hematoma. Rectus sheath hematoma. Then comes the recreational drugs. And you know that recreational drugs can cause acute abdominal pain. In many of the rave parties, you have seen that youngsters are taking cocaine or methamphetamine. So both of these are dangerous drugs. Why? Because cocaine and methamphetamine can cause intense vasospasm, and because of this intense vasospasm, there can be life-threatening cardiac or intestinal ischemia and severe hypertension. So what is the effect of recreational drugs? Recreational drugs like cocaine, methamphetamine, clear? So we discussed that both of these drugs are going to cause what? Intense vasospasm, and because of this intense vasospasm, there is intense vasospasm, and because of this intense vasospasm, what can happen? Life-threatening cardiac or intestinal ischemia, life-threatening cardiac or intestinal ischemia, and patient can develop severe hypertension. Severe hypertension. Clear? So these are the effects of drugs. So these drugs can create or mask the symptoms of acute abdomen. In females, careful gynecological history should be taken, especially in the evaluation of abdominal pain in young females. Why? Because here, the cause of acute abdominal pain, the DD can be ectopic pregnancy, it can be because of PID, it can be because of Mittel's purge, it can be because of severe endometriosis. So in the evaluation of acute abdomen, especially in young females, the DD should contain ectopic pregnancy, PID, Mittel's merge, and severe endometriosis. In physical examination, initial evaluation begins with general inspection. So suppose you are entering in the room where the patient is lying. What you're going to notice? You're going to notice that there is diaphoresis, there is pallor, patient is having dyspnea, and there is decreased alertness. It means it suggests some serious issue. If there is diaphoresis, pallor, dyspnea, or decreased alertness. We discussed that if patient is having peritonitis, whenever there is peritoneal inflammation, so patient tend to be very still. Why? Because movement, any kind of sudden body movement, it is going to aggravate the pain. So if patient is lying still, especially knee is flexed, we are going to suspect peritoneal inflammation also. So whenever we start inspection, clear? Inspection of abdomen focus on contour of abdomen and skin abnormalities. So it focuses on contour of abdomen, and skin abnormalities. Skin abnormalities. Clear? Some of the patients are having abdominal distension. And what are the causes of abdominal distension? It can occur because of intestinal obstruction, because of ascites, and if there is presence of a growing mass. So if you are going to examine the abdomen, perform the inspection, and you notice that there is abdominal distension. So it could be because of intestinal obstruction. Patient might be having ascites. There can be ascites, or there is a presence of growing mass. Skin abnormalities. What we are looking first, look for the scars. So any kind of scar suggestive of previous surgery. So it should be correlated with history taken, that what is the scar, any kind of surgery was done, how many years back, what was the problem at that point of time. Second thing, imagine you are going to notice erythema or blistering. Erythema or blistering suggests the possibility of soft tissue infection. So if in the skin abnormalities there is erythema or there is blistering, erythema or blistering, it suggests the possibility of soft tissue infection. Soft tissue infection. Second, imagine there is ecchymosis. If there is ecchymosis, it is an indication of facial necrotizing infection. So presence of ecchymosis, it's an indication of facial necrotizing infection. Facial necrotizing infection. Next is auscultation. So auscultation should be done prior to percussion or palpation, or it should be done after percussion or palpation. So ideally it should be done prior. It should be done prior to percussion or palpation. Why? Why it's done prior to percussion or palpation? Because bowel activity can be affected by manual manipulation. So if you are going to perform percussion or palpation, the bowel activity can be affected. So bowel activity can be affected by manual manipulation. That's why it should be done prior to percussion or auscultation. Now, if you are going to perform auscultation, imagine if you are going to hear bruit. So bruit is suggestive of vascular abnormalities. Patient might be having arterial stenosis or AV fistula. So on auscultation, if you are going to hear bruit, bruit is suggestive of vascular anomalies like arterial stenosis. It can be because of arterial stenosis or it can be because of AV fistula. AV fistula. Next, quantity and quality of bowel sound heard, it correlates with motility of bowel. Quantity and quality of bowel sounds heard, it correlate with motility of bowel. So if there is ileus, ileus is associated with hearing less than one bowel sound. Fewer than, it is associated with hearing fewer than one bowel sound. Fewer than one bowel sound every 15 seconds per quadrant. Every 15 seconds per quadrant. If patient is having ileus, you have to remember the values. So ileus, it is associated with hearing fewer than one bowel sound every 15 seconds per quadrant. And whenever patient is having mechanical bowel obstruction, what happens initially, there is hyperperistalsis, and because of this hyperperistalsis of bowel, there will be high pitched tinkling sound. So in mechanical bowel obstruction, there is high pitched tinkling sound. There is high pitched tinkling sound. So auscultation can be useful, but it must be correlated with history and other exam findings. Next is percussion. So obviously on the percussion, there is liver dullness. So there is dull resonance where in the right upper quadrant, and by measuring superior and inferior range, it gives the rough estimate of the liver size on percussion. Second, if there is localized dullness, it is suggestive of intra-abdominal mass. If patient is having hyperresonance or tympani, it means there is a presence of gas-filled structure deep to abdominal wall. If there is tympani in right upper quadrant, means there is presence of air between abdominal wall and liver, and in which case there is presence of air between abdominal wall and liver whenever patient is having intraperitoneal free air. So obviously in cases of perforation peritonitis. And if there is diffuse dullness, we are going to find this diffuse dullness in fluid filled abdomen. So on percussion, if there is localized dullness, it is seen in intra-abdominal mass. If patient is having intra-abdominal mass, There is hyperresonance or tympani. It means there is gas-filled structure. There is presence of gas-filled structure deep to abdominal wall. Gas-filled structure deep to abdominal wall. If there is tympani in right upper quadrant, means there is air between, there is presence of air between liver and abdominal wall. Liver and abdominal wall. And from where this air came, this air is actually, it's the free air, presence of free air because of perforation. So it is because of intraperitoneal free air. This is intraperitoneal. So this is intraperitoneal free air because of perforation. And whenever there is diffuse dullness here, patient is having fluid filled abdomen. In this case, patient is having fluid filled abdomen. Clear? Now, during percussion, exquisite tenderness can be seen. So whenever you are doing the percussion, there can be exquisite tenderness, and it is suggestive of peritonitis. So jostling abdominal viscera by percussing flank, iliac crest, or heel of extended lower extremity, it elicits the characteristic signs of peritonitis. It is going to elicit the characteristic signs of peritonitis. Characteristic signs of peritonitis. And it is more reliable. This is more reliable for detecting inflammation of peritoneal lining than deep palpation. So in comparison to deep palpation, if we are going to jostle the abdominal viscera by percussing flank, iliac crest, or heel of extended lower extremity, it is going to elicit the characteristic signs of peritonitis. Palpation localizes the source of pain and abnormalities within abdomen. It is of two types. One is superficial palpation and the second is deep palpation. Whenever we are starting the superficial palpation, it should be away from the area with most significant pain. So you should start, suppose a patient in whom you are suspecting that pain is in the right upper quadrant. So you should start from left lower quadrant. Clear? So palpation, it is going to localize, it localizes source of pain. Palpation localizes source of pain and it localizes abnormalities within abdomen. Abnormalities within abdomen. Clear? So it is of two types, superficial and deep palpation. We should start first superficial palpation and it should be away from the area with most significant pain. So superficial palpation, it allows for the assessment of masses of fluid collection anterior to abdominal wall. Fluid collections anterior to abdominal wall. Anterior to abdominal wall. Clear? Second, whether the pain is associated with these abnormalities or not, it is going to assess. So whether pain is associated with these abnormalities or not. Second is the deep palpation, and deep palpation helps in the assessment of pain from an intra-abdominal source and intra-abdominal mass or organomegaly. So deep palpation, it helps in assessment of pain from intra-abdominal source, intra-abdominal mass or organomegaly. Now imagine there is diffuse tenderness to palpation. If there is diffuse tenderness to palpation, it suggests that there is extensive inflammation or there is delayed presentation of an ongoing disease process. During palpation, we can assess guarding. Guarding can be voluntary guarding or involuntary guarding. You know that the involuntary guarding, it is a sign of peritonitis. But what is voluntary guarding? Whenever patient anticipates painful stimuli and tenses their abdominal wall muscles. So what happens in voluntary guarding? Whenever patient anticipates the painful stimuli going to tense the abdominal wall muscles. So how to prevent this? We ask the patient to lie supine, bend the legs and take deep breaths. If patient is bending the legs, what? The lower abdominal muscles are relaxed. And whenever patient is taking the deep breaths, what? Upper abdominal muscles are relaxed. So how to prevent voluntary guarding? Patient should lie supine, legs flexed, and patient should take deep breaths. Deep breaths. Clear? So the attention of patient is also diverted. Upper abdominal muscles and lower abdominal muscles are relaxed. This is voluntary guarding, and we discussed involuntary guarding. It's a sign of peritonitis. Involuntary guarding, it's a sign of peritonitis. So this is important. It's a sign of peritonitis. Now see the important abdominal examination signs. First on history, there is Danforth sign. So what is this Danforth sign? On history. Clear? So in this case, what happens? There is shoulder pain on inspiration. Why there is shoulder pain on inspiration? If patient is having hemoperitoneum, so there is irritation of dome of diaphragm. So what happens here? There is shoulder pain on inspiration. In this patient, there is shoulder pain on inspiration. Shoulder pain on inspiration. And it is seen in which condition? It is seen in hemoperitoneum. This is seen in hemoperitoneum. Clear? After that, see the abdominal signs on inspection. On inspection, there is cruel hair sign. And what is this cruel hair sign? There is varicosity at umbilicus. So there is varicosity or varicose vein at umbilicus, and you know that it is seen in which condition? It is seen in portal hypertension. So cruel hair sign, it is seen in portal hypertension in which there is varicosity at umbilicus. Next is Cullen sign. You know that Cullen sign, it is seen in which patient? Patients of acute pancreatitis in which there is hemorrhage. So there is peri-umbilical ecchymosis or peri-umbilical bruising. So it is seen in which patients? Patients of acute pancreatitis in which there is hemorrhage. So which is associated with retroperitoneal hemorrhage or sometimes hemoperitoneum. Retroperitoneal hemorrhage or hemoperitoneum. That is Cullen sign. After that, there is Gray Turner sign. In Gray Turner sign, there is ecchymosis around flank. And here also, ecchymosis around flank. Here also, the situation is same. It is seen in patients of acute pancreatitis whenever there is retroperitoneal hemorrhage. And what happens? There is bleeding along the facial planes. Next is Ronso-Hoff sign. What is this Ronso-Hoff sign? There is yellow discoloration of umbilical region. So why there is yellow discoloration of umbilical region? Because there is ruptured CVD. In this case, why there is yellow discoloration of umbilical region? Because of ruptured CVD. It's because of ruptured common bile duct. Now see the abdominal signs on palpation. In acute appendicitis, there is pain in epigastrium upon continuous firm pressure over McBurney's point. This is known as Aron sign. So what is Aron sign? It is seen in acute appendicitis. Acute appendicitis. Clear? So here, pain in epigastrium on continuous firm pressure over McBurney's point. Second is basilar sign. So what happens in basilar sign? There is sharp pain created by compressing appendix between abdominal wall and iliacus. And this one is seen in chronic appendicitis. This is seen in chronic appendicitis. Clear? So which sign? Basilar sign, in which there is sharp pain caused by compressing appendix between abdominal wall and iliacus. Next is Bloomberg sign. What happens in Bloomberg sign? There is transient abdominal wall rebound tenderness. And transient abdominal wall rebound tenderness, it is seen in which condition? Obviously, peritoneal inflammation. So Bloomberg sign, it is seen in peritoneal, positive in peritoneal inflammation. It's positive in peritoneal inflammation. Next is Carnett sign. So what happens in Carnett sign? There is loss of abdominal tenderness when abdominal muscles are contracted. So when abdominal muscles are contracted, there is loss of abdominal tenderness, in which case whenever there is intra-abdominal source of abdominal pain. So this is Carnett sign. Whenever there is intra-abdominal source of abdominal pain, this sign is positive, known as Carnett sign. So loss of abdominal tenderness when abdominal wall muscles are contracted. What is Chandelier sign? Here there is extreme pelvic pain with movement of cervix, and it is positive in pelvic inflammatory disease. Extreme pelvic pain with movement of cervix. It is positive in PID. This is Chandelier sign. After that, there is Courvoisier sign. What is the Courvoisier sign? There is palpable gallbladder when jaundice is present. So, palpable gallbladder when jaundice is present. And obviously, this sign is positive when patient is having periampullary mass. So, Courvoisier sign, it is positive when patient is having periampullary mass. There is periampullary mass. And what is Courvoisier's law? In a case of obstructive jaundice, gallbladder is seldom palpable due to stone disease. So, in a case of obstructive jaundice, gallbladder is palpable because of periampullary carcinoma. That is Courvoisier's law. And here, palpable gallbladder when jaundice is present. This is Courvoisier's sign. After that, there is Fothergill sign. So, what is this Fothergill sign? Here, abdominal wall mass that doesn't cross the midline. Abdominal wall mass that doesn't cross the midline and is palpable when rectus is contracted. Clear? And this one, it is positive in rectus sheath hematoma. So, Fothergill sign, it is positive in rectus sheath hematoma. Rectus sheath hematoma. Next is iliopsoas sign. So what happens here? Elevation of extended leg against the resistance is painful. So it is positive in appendicitis. Which type of appendicitis? It is positive in retrocecal acute appendicitis. Why? Because the appendix is located behind the cecum. That's why elevation of extended leg against the resistance, it is painful. So it is positive in retrocecal acute appendicitis. Retrocecal acute appendicitis. Okay, next is Murphy's sign. We already discussed it in gallbladder. So what is this Murphy's sign? There is pain caused by inspiration while applying the pressure to right upper abdomen or right upper quadrant. Pain caused by inspiration while applying pressure to right upper abdomen. And you tell me it is positive in which particular condition? It is positive in acute cholecystitis. So Murphy's sign, it is positive in acute cholecystitis. Acute cholecystitis. Obturator sign, again it is positive in acute appendicitis. So what happens here? Flexion and external rotation. Here, flexion and external rotation of right thigh creates hypogastric pain, and it is positive in acute appendicitis. What should be the orientation? The orientation should be pelvic. So it is positive in pelvic appendicitis, sometimes positive in pelvic abscess. So it is positive in pelvic appendicitis, pelvic appendicitis, or pelvic abscess. Pelvic abscess. There are two other signs. One is Rosing sign and one is Tenhorn sign. Rosing sign, this is the most characteristic sign of acute appendicitis. So what happens here? There is pain at McBurney's point whenever we are palpating the left lower quadrant. So pain at McBurney's point when palpating the left lower quadrant, and it's positive in acute appendicitis. This is most characteristic sign. This is most characteristic sign of acute appendicitis. And what is Tenhorn sign? Gentle traction of right testis leads to pain. So pain caused by gentle traction to right testis, and again it is positive in acute appendicitis. Clear? So you have to remember these signs. These are very, very important, and almost every year at least one sign is asked in exam. Now what is the role of digital rectal examination in acute abdomen? So it provides information related to hollow viscous bleeding and source of distal obstruction which is causing constipation or obstipation. Constipation or obstipation. So digital rectal examination, it provides information related to hollow viscous bleeding and source of distal obstruction causing constipation or obstipation. What are the important laboratory investigations which should be done in patients of acute abdomen? So whenever there is perforation, there is acute infection. What happens? There is increased WBC count, and especially there is increased band cells. So obviously we go for TLC, total leukocyte count, and we go for DLC. So in patients of acute abdomen, there is increased risk of acute infection, especially if there is perforation. So in acute infection, there is increased WBC count, TLC, DLC should be done. Why? Because especially band cells are increased. So increased WBC count is there. That's why what we are going to advise, TLC, total leukocyte count, DLC, differential leukocyte count. Now imagine at the time of presentation, patient is having higher hemoglobin or patient is having higher hematocrit. It is an indirect evidence of dehydration. So these patients should be evaluated for signs of dehydration. Whenever patient is having higher hemoglobin or higher hematocrit, these patients should be evaluated for signs of dehydration. After that, if a patient is having vomiting, patient is having diarrhea, you know that it leads to dyselectrolytemia. So if there is dyselectrolytemia involving sodium, potassium, calcium, we have to suspect diarrhea, vomiting, or some kind of endocrine disorder like endocrine sources of abdominal pain like hyperparathyroidism. So third, in laboratory investigation, if the patient is having dyselectrolytemia, especially the levels of which electrolytes? Yes, sodium, it's the potassium, calcium, clear? So alteration of these values suggest diarrhea, seen in diarrhea, vomiting, or sometimes endocrine sources of abdominal pain like hyperparathyroidism. After that, we have to go for liver function test, kidney function test, amylase and lipase. So what else? LFT, KFT, liver function test, kidney function test. What is the significance of amylase or lipase? You know that if amylase is raised or lipase is raised, what? Pancreatitis is suspected. So whenever there is increased amylase or lipase level, acute pancreatitis is suspected. Clear? In severely ill patient, you have seen the patients who are in ICU or in critical care units. In those cases, we go for ABG with serum lactate. So ABG with serum lactate, clear? It is done especially in severely ill patient. Now why? Because you know that lactic acidemia, it's a sign of hypoperfusion. So whenever there is lactic acidemia, it is a sign of poor perfusion. So it's a pointer for mesenteric ischemia. So imagine if a patient is having lactic acidemia, it is seen in, or it's a sign of poor perfusion, hypoperfusion. So it's a pointer for mesenteric ischemia. In patients of mesenteric ischemia, there is raised level of lactic acid. So lactic acidemia, it's a pointer for mesenteric ischemia. After that, urine studies. So suppose you are sending urine routine and microscopic examination, culture and sensitivity, and we are going to find bacteria, WBC, or there is leukocyte esterase. It is positive, it is suggestive of infection, and this infection can be UTI or patient might be having pyelonephritis. So in urine studies, presence of bacteria, increased WBCs, leukocyte esterase, it is suggestive of infection. This is suggestive of infection. So patient might be having what? Urinary tract infection, or the patient might be having pyelonephritis. Urinary tract infection, or patient might be having what? Pyelonephritis. Second situation, imagine there is presence of RBCs in urine, means patient is having hematuria. It might be macroscopic or microscopic. So if there is presence of RBCs, it can be because of renal stone, means nephrolithiasis, and it is also seen in nephritic syndrome. So what? If there is presence of RBCs in urine, it is seen in both kidney stones, so that's nephrolithiasis, and nephritic syndrome. You know that in nephritic syndrome there is hematuria. nephritic syndrome. So these are the important laboratory investigations done. Now see the diagnostic imaging. So diagnostic imaging is the final step in workup of patient with acute abdomen. It's the final step in the workup of a patient with acute abdomen. Now, what is the best modality for evaluating right upper quadrant pain? You know that it's ultrasound. Why? Because ultrasound, it is having high sensitivity and specificity for detecting what changes in the liver and especially in the gallbladder. So if there is pericholecystic fluid, patient is having gallbladder thickening, patient is having gallstones, for all these, ultrasound is having very high sensitivity and specificity. So first important point, ultrasound, it's the best modality. Ultrasound is the best modality for evaluation of right upper quadrant pain. Why? Because it is having high sensitivity and specificity for detecting pericholecystic fluid, gallbladder wall thickening and gallstones. So you know that ultrasound is the investigation of choice for what? Gallstones, acute cholecystitis, chronic cholecystitis, urinary bladder stone and acute appendicitis in children. Apart from that, it is investigation of choice for hypertrophic pyloric stenosis. There is another role of ultrasound that it's useful in early pregnancy. So important point, ultrasound is the investigation of choice for diagnosis in acute appendicitis in children, acute appendicitis in children, hypertrophic pyloric stenosis, which is also known as infantile hypertrophic pyloric stenosis, gallstones, acute cholecystitis, doesn't matter, it is acute calculus cholecystitis or chronic cholecystitis, and it is investigation of choice for diagnosis of urinary bladder stone. Simultaneously, it is useful, this is useful in early pregnancy also. This is useful in early pregnancy also. In early pregnancy. But sometimes what's the problem? There is limitation with visualization. In ultrasound, there is limitation with visualization. Why? Because of abdominal wall thickness. So if patient is obese having thick abdominal wall, in that case there is difficulty in visualization. Second, if there is bowel gas content. And third problem, it is operator dependent. So limitation with visualization due to operator experience. So if an inexperienced person is there, obviously he might not visualize the organs properly. So with the help of plain film abdomen, we can detect hollow viscous perforation. So what happens? Upright film is taken at the level of diaphragm, and whenever upright film is taken at the level of diaphragm, you will notice that there is presence of free air under right dome of diaphragm. That is diagnostic. So either we can go for plain film of abdomen, and here you can see this is chest x-ray. Here also you can see that there is presence of free air under right dome of diaphragm. So this free air under right dome of diaphragm, it is suggestive of what? Pneumoperitoneum. This is perforation. So on plain film abdomen, we can easily detect what? Hollow viscous perforation. Hollow viscous perforation. By chest x-ray also it can be detected. And what you are going to see, you are going to find free air under right dome of diaphragm, means pneumoperitoneum. So there is free air under right dome of diaphragm, under right dome of diaphragm, that is pneumoperitoneum. Now imagine a patient is having hollow viscous perforation. What is the role of CT? So CT provides more information related to location of perforation and specific cause. So what's the role of CT here? CT is more important to provide information related to location of perforation. So location of perforation and cause of perforation. It provides information related to location and cause of perforation. Cause of perforation. If we suspect intestinal obstruction or bowel obstruction, then there is a role of upright film and supine films of abdomen. Clear? Now how we differentiate small bowel obstruction from large bowel obstruction? You know that small bowel, it is placed centrally. So in small bowel obstruction, the dilated bowel loops are present centrally. These are narrow in caliber. And if it is jejunum, there is circumferential ring-like pattern known as volvuli conniventis. And in large bowel obstruction, the loops are placed peripherally, which is wider in caliber, and there is presence of haustration. Now let's compare these two upright films of abdomen. If you see here, the bowel loops are placed centrally. These bowel loops are narrow in caliber, and if you look carefully here, what you can see, if you look carefully, there is circumferential ring-like pattern, and this circumferential ring-like pattern, this is volvuli conniventis. So this circumferential ring-like pattern, which is known as volvuli conniventis, is the characteristic feature of what? Characteristic feature of jejunum. So in jejunum, you will find what? Volvuli conniventis. There is volvuli conniventis, that is circumferential ring-like pattern. And what about ileum? Whenever ileum is distended, ileum is featureless, or it is said that it is characteristically characterless. So there is no special feature of ileum, but in jejunum there is volvuli conniventis. If you see this is the large bowel, you might identify the loop. What? This is ascending colon, then this is the transverse colon, this is the descending colon. And what you can see the haustration, you can see the caliber. So if you see the location, yes, it is peripheral. This is small bowel obstruction and this is large bowel obstruction. Important point, dilated bowel loops are placed peripherally. So these are placed peripherally. This is wider in caliber, and there is presence of haustrations. Wider in caliber and there is presence of haustrations. Clear? There is another finding which can easily be detected on X-ray. If there is gas in the rectum, there is partial obstruction, and absence of gas in rectum, it is suggestive of complete obstruction. So in these two images, we can easily compare small bowel obstruction and large bowel obstruction. If you see the supine view, here dilated bowel loops are there. Dilated bowel loops placed centrally, narrow in caliber, and since there is presence of circumferential ring-like pattern, these loops are jejunum. And here on upright view, there are dilated bowel loops, and there is air fluid level in step ladder pattern. Same thing here. In large bowel, you can see dilated bowel loops placed peripherally, wider in caliber, there is presence of haustrations, and here you can see air fluid levels in upright view. See this image, this is sigmoid volvulus, and here you can see this is coffee bean sign. Can you see here? This is coffee bean sign. So on this plain X-ray, you can see sigmoid volvulus with coffee bean sign. There is another sign. What? You can see this is bent inner tube, and this is what? Omega sign. So bent inner tube and omega sign. And if you see this apex of dilated colon, it is pointing towards right upper quadrant. So in sigmoid volvulus, apex of dilated colon, it is pointing towards right upper quadrant. So these are frequently asked signs. On X-ray, there is coffee bean sign, bent inner tube sign, there is omega sign, and apex of dilated colon, it is pointing towards right upper quadrant. There is another volvulus which is asked frequently, cecal volvulus. So in cecal volvulus, there is comma shaped cecum. What is the shape? It is something like this. Clear? So there is comma shaped cecum. And what kind of bean? There is kidney bean sign. If you see the concavity is facing inferiorly and towards right. So concavity, it is facing inferiorly and towards right. Clear? So these are the important signs in cecal volvulus. Comma shaped cecum. There is kidney bean. In sigmoid volvulus, it was coffee bean. Here it's kidney bean, and the concavity is facing inferiorly and towards the right. Now see what's the role of CT. You know that it's the non-contrast spiral CT, which is the most sensitive investigation for renal and ureteric calculus. So what is investigation? Non-contrast spiral CT. Non-contrast spiral CT. This is most sensitive investigation for renal as well as ureteric calculus. For renal and ureteric calculus. Ureteric calculus. So sometimes this question is asked indirectly, that what is the investigation of choice for diagnosis of renal calculus or ureteric calculus? This is non-contrast spiral CT because it is most sensitive. This is most sensitive. Clear? Whenever we are suspecting bowel obstruction, then we perform CT with oral as well as IV contrast. It is not done in all cases, but it is useful for the patients in whom there is high grade obstruction, there are extraluminal causes of intestinal obstruction, or patient is having strangulation. So what's the role of CT with oral and IV contrast? In bowel obstruction, it is not done routinely. It is not done routinely, but it is preferred whenever there is high grade obstruction, there are extraluminal causes of obstruction, or complication is there like strangulation. Another important point, if we suspect appendicitis, we go for ultrasound. But which investigation is considered gold standard investigation for acute appendicitis? It is CCT. So another important point related to CT, that CCT, this is the gold standard. This is the gold standard investigation for acute appendicitis. For acute appendicitis. So whenever the diagnosis is equivocal, we are not sure whether patient is having acute appendicitis or not, and we have to confirm it, yes, we go for CCT. So here, with the help of CCT, there is earlier diagnosis. But one important point you have to remember, that even if you are going to perform CCT, it results in earlier diagnosis, but it will not decrease hospital stay or morbidity. Now suppose a child is there, or patient who undergo frequent imaging because of some pathology. So if a child is there, or a patient who require frequent imaging because of the underlying pathology, in such cases we go for low dose CT. So low dose CT should be considered in which patients? Low dose CT. Low dose CT, it should be considered in children and the patient who require frequent imaging. Patients requiring frequent imaging. Clear? In these cases, we go for low dose CT. Now, what is the role of diagnostic laparoscopy? See, diagnostic laparoscopy can be used as final diagnostic adjunct if other tests are equivocal. So if other tests prove equivocal, diagnostic laparoscopy can be used as final diagnostic adjunct. But what is the problem? Diagnostic laparoscopy should not be used when irreversible sepsis is present, and if operator is uncomfortable with laparoscopy. So in these two cases, whenever there is irreversible sepsis or the operator is uncomfortable with laparoscopy, in these cases we should not go for diagnostic laparoscopy. Now another situation, imagine patient is having small bowel obstruction and what? There is extremely dilated bowel. So if a patient is having extremely dilated bowel, is a contraindication or not? So extremely dilated bowel, it's a relative contraindication to diagnostic laparoscopy. It is relative contraindication. Why it is relative contraindication to diagnostic laparoscopy? Because it limits complete exploration. So in this case also we should avoid diagnostic laparoscopy. So another question, diagnostic laparoscopy should be used routinely or not in patients of acute abdomen? You know the answer, that diagnostic laparoscopy should not be used routinely. It can assist determining the cause of acute abdomen in selected cases. So only in selected cases. It is done only in selected cases. It should not be done routinely. And we discussed what are the contraindications. And we discussed what are the situations in which it should not be done. Whenever you are suspecting irreversible sepsis and if operator is uncomfortable with laparoscopy. What is the importance of intra-abdominal pressure monitoring? First, what is the normal intra-abdominal pressure? It is 5 to 7 mmHg. So normal intra-abdominal pressure, that is 5 to 7 mmHg. 5 to 7 mmHg. There are certain situations which are going to increase intra-abdominal pressure artificially. Like if a patient is having abdominal opacity, patient is using accessory muscles for respiration, and if there is upright positioning. So these are going to increase intra-abdominal pressure artificially. Abdominal obesity accessory muscle respiration and upright position. Now, second important point, what's the relation with acute abdomen? Acute abdomen can cause increased intra-abdominal pressure, and sometimes it can be due to increased intra-abdominal pressure. So, what is the relevance in cases of acute abdomen? Acute abdomen can cause increased intra-abdominal pressure, or it can be due to increased intra-abdominal pressure. So what is the pathophysiology in this case? See, whenever intra-abdominal pressure is raised, what will happen? There is compression of IVC. Clear? So because of increased intra-abdominal pressure, IVC is compressed, and if IVC is compressed, what will happen? It is going to decrease the venous return. Clear? Second, because of increased intra-abdominal pressure, the diaphragm is pushed up, and if diaphragm is pushed up, what will be happening? There is decreased tidal volume. So there is decreased venous return to heart, there is decreased tidal volume, and because of this there is elevated inspiratory pressure. So diaphragm is pushed up, there is elevated inspiratory pressure, that's why there is decreased tidal volume, there is decreased venous return to heart. So what will happen? It decreases the cardiac output. If cardiac output is decreased, what does it mean? Patient is having hypotension, so there is decreased renal blood flow. If there is decreased renal blood flow, it is going to decrease the GFR, glomerular filtration rate, and what will happen? There is decreased urine output. So initially, if you see in patients of intra-abdominal hypertension, or whenever patient is going to develop abdominal compartment syndrome, what will happen? Yes, there is initially oliguria and then there is anuria. Now, what is abdominal compartment syndrome? You have to remember the definition. In ACS, abdominal compartment syndrome, if intra-abdominal pressure is sustained above 20 mmHg. So intra-abdominal pressure is sustained above 20 mmHg. Clear? So in such patients there is decreased venous return. Because of that there is decreased cardiac output, there is decreased renal blood flow, decreased GFR, decreased urine output. Since patient is having hypotension, there will be decreased visceral blood flow. And since there is decreased visceral blood flow, patient is having visceral ischemia. It leads to visceral ischemia. Clear? Now, how we are going to measure the intra-abdominal pressure? Gold standard indirect method to measure intra-abdominal pressure, what we insert the bladder catheter. So it is bladder catheter pressure monitoring. So gold standard indirect method to measure intra-abdominal pressure, that is bladder catheter pressure monitoring. This is bladder catheter pressure monitoring. Many times this question was asked. Bladder catheter pressure monitoring. So there are recommendations for bladder catheter pressure monitoring by World Society of Abdominal Compartment Syndrome. So WSACS. This is the World Society of Abdominal Compartment Syndrome. And what are the recommendations of World Society of Abdominal Compartment Syndrome for measuring bladder pressure? First, what we had to do, we had to instill 25 ml of room temperature saline in bladder. So instill how much? 25 ml of room temperature saline. Room temperature saline in bladder. Instill how much ml? 25 ml of room temperature saline into bladder. What should be the position of patient? Patient should be in supine position. So the patient should be in the supine position. So patient should be supine with transducer at zeroed at mid axillary line. And this pressure management should be taken at the end of expiration. So the measurement should be taken at the end of expiration. It should be taken at the end of expiration. Clear? So these are the recommendations of World Society of abdominal compartment syndrome for measuring bladder pressure. Now see the treatment of intra-abdominal hypertension and abdominal compartment syndrome, it depends on the cause and severity. So this treatment, it depends on cause and severity of intra-abdominal hypertension and abdominal compartment syndrome. Now imagine patient is having primary abdominal compartment syndrome. What do you mean by that? Primary abdominal compartment syndrome, it is due to disease process within abdomen. Clear? Disease processes within the abdomen, and that's why this is best treated with decompressive laparotomy. Primary abdominal compartment syndrome and correction of inciting disease process. Second situation is secondary abdominal compartment syndrome, and this secondary abdominal compartment syndrome, it arises from a condition not located in abdomen or pelvis. So if a patient is having secondary abdominal compartment syndrome, usually these patients are having systemic illness. So we have to treat that illness which is causing secondary abdominal compartment syndrome. So we discussed primary abdominal compartment syndrome. Primary abdominal compartment syndrome, and it is due to disease process within abdomen. It is because of disease process within the abdomen. And since disease processes within the abdomen, which is increasing the intra-abdominal pressure, so what we should go for decompressive laparotomy and correction of inciting disease process. So here we perform decompressive laparotomy and correction of inciting disease process. Inciting disease process. And we discussed there is secondary abdominal compartment syndrome. So this is secondary, and secondary is secondary to condition that is not located in abdomen or pelvis. So this is because of condition. It's because of condition not located in abdomen or pelvis. Not located within abdomen or pelvis. Within abdomen or pelvis. Clear? This is secondary abdominal compartment syndrome. So what is the initial management of abdominal compartment syndrome without evidence of end organ disease? Here, the patient should be treated medically. So medical management of abdominal compartment syndrome includes correcting a positive fluid balance and evacuating intraluminal contents. So how we can evacuate intraluminal content? Yes, the bowel and gastric content can be evacuated by nasogastric tube. Bladder content evacuated by Foley's catheter. Foley's catheter. Clear? And fecal content, it is evacuated by enema. Enema. So evacuating intra-abdominal content, obviously it is going to decrease the intra-abdominal pressure. Second, we can relax the abdominal wall with adequate sedation and pain control. Relaxing abdominal wall with adequate sedation and pain control, and drainage of peritoneal fluid. So if we insert the drain, what happens? Obviously intra-abdominal pressure comes down because we are going to drain the peritoneal fluid. But important point, whenever we are managing the patient medically, there should be low threshold for decompressive laparotomy to limit morbidity and mortality. Now see the treatment of abdominal hypertension by its grade. First see the grading. Normal pressure we discussed, it is 5 to 7 mmHg. What is grade 1 intra-abdominal hypertension? So grade 1 is when the pressure is 12 to 15. Grade 2 when it's 16 to 20 mmHg. Grade 3 21 to 25, and the grade 4 whenever it's more than 25 mmHg. Obviously if the pressure is normal, no treatment is required. None. Whenever patient is having grade 1 hypertension, pressure is 12 to 15 mmHg, here maintain euvolemia. So in this case we have to maintain euvolemia. If patient is having grade 2 hypertension, pressure is 16 to 20 mmHg, in this case we go for non-surgical decompression. So we have to decrease the fluid. How? By diuresis. So we go for non-surgical decompression for grade 2. Obviously, in grade 3, we have to go for surgical decompression, and what we have to perform laparotomy. So in grade 3, surgical decompression with laparotomy. So it's the surgical decompression, and how we are going to do it? Via laparotomy. So surgical decompression via laparotomy. It should be done. And whenever it is grade 4, pressure is more than 25 mmHg, here surgical decompression should be done. Simultaneously, we have to explore or look for the cause. So surgical decompression and explore for cause. Explore the abdomen for cause. Explore for cause. So this is very, very important. They ask the grading, they ask the pressure, they ask the management. Now sometimes we are faced with this situation in emergency that patient is not stable enough to be transported to another department, especially radiology department, for some of these tests. So in these situations, what we have to go for, we can go for bedside investigations. And which investigations are done bedside? You have seen. One is ultrasound. So bedside ultrasound can be done, or bedside abdominal plain films can be taken. So if patient is not stable enough, patient is not stable enough to be transported, not stable enough to be transported to other department. In these patients, we go for bedside investigations. And which bedside investigation? We can go for bedside ultrasound. We can go for bedside ultrasound or bedside abdominal plain film. Abdominal plain film. There is other option what we can perform diagnostic peritoneal lavage. Clear? If the patient is not stable enough to be transported to another department. In this image, you can see that how we are going to perform DPL diagnostic peritoneal lavage. First, we have to give midline incision in the infraumbilical region. So midline incision in infraumbilical region is given. After that, a catheter is directed towards pelvis. Here you can see this is DPL catheter. So this catheter, it is directed towards pelvis. In this image you can see. Clear? So catheter, it is directed towards pelvis, right? After that, 1 liter normal saline. 1 liter of normal saline is infused. And when normal saline is going into this peritoneal cavity, after that you can see that 1 liter of normal saline, it is siphoned out. So here you can see it is getting collected in the bag. Clear? And that fluid is collected in the bag. So this siphoned fluid, which is also known as effluent, it is sent for cellular and biochemical analysis, right? So suppose you are performing DPL, diagnostic peritoneal lavage, in trauma patient. Clear? What you can detect? So DPL, it is used to detect hemoperitoneum and or hollow viscous perforation. So DPL, it is used to detect hemoperitoneum and or hollow viscous perforation Now, important point which we have to remember, especially in patients of acute abdomen, that delay in surgical intervention should be avoided. Why delay in surgical intervention should be avoided? Because morbidity and mortality increases with unwarranted delays. Second important point, whenever patients of acute abdomen are brought to the emergency, sometimes they are unstable also. So fluid resuscitation and stabilization of vital signs, it can continue in operating room, especially the patients in whom we suspect mesenteric ischemia or the patients who are having bowel infarction. These patients are immediately taken to operating room just after diagnosis. We are not going to waste time in fluid resuscitation and stabilization. Why? Because fluid resuscitation and stabilization, it can be done and it can be continued in the operating room. What is the role of laparoscopy in acute abdomen? So you know that laparoscopy can assist in guiding placement of laparotomy incision because it will tell you the pathology. So if a patient is forced to proceed to operating room without definitive diagnosis, in that case we can go for laparoscopy followed by laparotomy. So if a patient is forced to proceed to operating room without a definitive diagnosis, in such cases we can go for laparoscopy. So laparoscopy will tell you about the organ involved or the site of pathology, and it assists in guiding laparotomy incision. So whenever we are taking the history, we are performing examination, we are performing the investigations. So what are the findings that suggest the need for surgical intervention in patients of acute abdomen? First, see the physical examination findings. So whenever abdominal compartment pressure, it is more than 25 mmHg. Abdominal compartment pressure, it is more than 25 mmHg. It means it is pointing towards abdominal compartment syndrome. Patient is having involuntary guarding. We discussed that involuntary guarding, it is seen in peritonitis. If patient is having rebound tenderness, again there is peritoneal inflammation. So these findings are present in the patients who are having peritonitis, and obviously we have to go for surgical intervention. Whenever there is pain out of proportion to exam, and usually this is seen in patients of mesenteric ischemia. It is seen in patients of mesenteric ischemia. Clear? Mesenteric ischemia. So in these cases also early intervention is required. The resuscitation can be done in the operating room if patient is having unexplained systemic sepsis, or if there is trans-abdominal penetrating trauma, because there is increased risk of significant intra-abdominal organ injury. So in all these cases of physical exam findings, we should go for surgical intervention. Now see the laboratory findings. Now imagine a patient is having anemia from GI hemorrhage, gastrointestinal hemorrhage leading to anemia, patient is requiring more than 4 units of blood transfusion. Clear? It means there is ongoing blood loss or there is significant blood loss. Second is there is evidence of hypoperfusion. So you know that if patient is having hypoperfusion, what are the findings? There will be acidosis. The creatinine level will start rising. Why? Because there is hypoperfusion of kidney, rising liver function test. So what are the evidences here? There is acidosis, rising creatinine, and rising liver function test. Clear? So in these cases also surgical intervention is required. After that, see the diagnostic imaging findings. So if patient is having pneumoperitoneum, obviously it is suggestive of perforation peritonitis, and here laparotomy is required. Pneumoperitoneum suggestive of perforation, laparotomy is required. If there is progressive dilatation of stationary loop of intestine, which is also known as sentinel loop, here also surgical intervention is required. Whenever there is evidence of bowel perforation, how? Obviously there will be presence of free air, or there is contrast near loop of bowel. So presence of free air under right dome of diaphragm, and if some contrast study was done, you will find the contrast near the bowel loop. If there is fat stranding or thickened bowel wall with systemic sepsis, it means that area is containing the inflammation. Or patient is having bowel wall pneumatosis, it might be seen in pneumatosis intestinalis. So in all these cases, we should go for surgical intervention. Findings of diagnostic peritoneal lavage, in which we consider the taking patient for surgery. So if there is presence of feculent or particulate matter, it means patient is having perforation. There is hollow viscous perforation. Whenever WBCs are more than 250 per mm cube, RBCs more than 3 lakh per mm cube, it is suggestive of what? Significant bleeding. In this case also surgical intervention is required. Whenever peritoneal bilirubin, it is more than serum bilirubin. Why peritoneum bilirubin is more than serum bilirubin? Obviously, because in this patient, bile leak occurred. There is bile leak. And whenever there is peritoneal creatinine more than serum creatinine, in such patients, there is urine leak. So usually these are trauma patients in which we are performing diagnostic peritoneal lavage, and these are the indications of taking the patient for surgical intervention. So regardless of patient severity of illness, all patients require some degree of preoperative preparation. And what we do whenever we are planning to take this patient for surgery, obviously first IV access should be obtained. Fluid or electrolyte abnormality is there, it should be corrected. Now, in acute abdomen, whenever it is because of perforation, you tell me what is the most common organism responsible for acute abdomen. So, most common organism in acute abdominal emergencies, it is obviously E. coli. So, that is gram-negative enteric bacilli, followed by anaerobes, that is Bacteroides fragilis. So, the organisms are gram-negative enteric organisms and anaerobes. So we have to give antibiotics also to cover these organisms. So in preoperative preparation, IV access should be obtained and fluid should be started. What is the fluid of choice? Ringer lactate. If patient is having fluid and electrolyte abnormality, it should be corrected. Fluid and electrolyte abnormality, it should be corrected. In majority of cases, what is the organism responsible for acute abdominal emergencies? It is E. coli. So it's gram negative. Enteric organisms, clear, and anaerobes. Usually it's because of perforation peritonitis whenever there is fecal contamination, and you know that in fecal matter there is E. coli and Bacteroides fragilis. Clear? Antibiotic infusion should be given and it should cover these organisms. What is the role of nasogastric tube placement? So we are going to insert the Ryle's tube or nasogastric tube. Why? To decrease the likelihood of vomiting or aspiration. So for proximal decompression, it is done for proximal decompression to decrease the likelihood of vomiting and aspiration. Foley's catheterization, why? Because we want to monitor urine output. So it is done for urine output monitoring. Why? Why urine output monitoring? Because you know that best clinical indicator of tissue perfusion, that is urine output. So in an adult, after adequate tissue perfusion, how much should be the minimum urine output? 1 ml per minute. In an adult, after adequate tissue perfusion, how much should be the minimum urine output? It should be 1 ml per minute. Now, we discussed that. What's the cause of acidosis? It is because of hypoperfusion. If acidosis, it is because of intestinal ischemia or infarction, it may be refractory to preoperative therapy. So this thing you have to keep in mind, that acidosis due to intestinal ischemia or infarction may be refractory to preoperative therapy. So need for preoperative stabilization must be weighed against increased morbidity and mortality associated with delay in treatment, and we discussed that resuscitation and stabilization can continue in operating room also. It means if a patient is having infarcted bowel, in these patients, what? Surgical correction. These patients may require surgical correction before stabilization of patient's vital signs and restoration of acid-base balance. So what here? Surgical correction. Why? Because we discussed that if patient is having acidosis because of intestinal ischemia or infarction, it may be refractory to preoperative therapy. So patients who are having bowel infarction may require surgical correction before stabilization of patient vital signs and restoration of acid-base balance. And another important point, resuscitation should be viewed as ongoing process. It should be viewed as ongoing process. It means it's continued after surgery is completed. So it's continued even after surgery is completed. After surgery is completed.